Good morning, everybody. Welcome to another APSAD Insight webinar. I'd like to pay a particular thank you to APSAD for facilitating the presenter that we've got today. So thank you, APSAD. My name's Jim Hunt. I'm one of the nurse educators here at Insight. Before we kick off, I'd like to acknowledge the traditional owners and custodians of the land on which we're meeting today. I'd like to pay my respects to any elders past, present or emerging, and I'd like to extend that welcome and respect to any Aboriginal or Torres Strait Islanders that might be joining us on webinar land. So welcome and thank you. I think you're in for a bit of a treat today. We've got a bit of a special guest. We've got Prof McKetin, who is an associate professor with NDARC, the National Drug and Alcohol Research Centre down at the University of New South Wales. And she's published about 150 papers on the topic that we're about to discuss today. So without any further ado, I'd like you to welcome Associate Professor Rebecca McKetin, who's going to talk about treatment approaches for stimulant use. So thank you, and over to you, Rebecca.
Thank you very much, Jim, and thank you for everyone else coming along today. As Jim said, I'm an Associate Professor at NDARC down in Sydney at the University of New South Wales. And today I'm going to be talking about the treatment of stimulant use, what the evidence says. And I have to admit, when I was first approached about doing this talk, I was a bit reluctant. And I came back and I said, look, I don't provide treatment. And I wasn't sure that I was the best speaker on this topic, but I insisted that if I do speak, I'll be speaking only about the evidence. So today I will be talking about the evidence, and you might like some of it, you might not like some of it, but please don't shoot the messenger. I think it's important that we all at least know what we do and don't know about this topic. Now, I might have written 150 or so papers on methamphetamine use, but today I'll only be talking about one of them. And this is a paper that my colleagues and I recently published in The Lancet. I'd like to acknowledge all of them listed here, if you can see all of their many names. And particularly Michael Farrell, who's the lead author on this paper. Now, this is a paper that's from a series published in The Lancet on drug use. And if you haven't seen this, I would strongly encourage you to go and take a look at it, because not only does it provide a really nice overview of the current situation with regard to the major drug types and what we know about treating them and where we need to go, but it also has a wonderful editorial, which I think is quite invigorating. So today I'll just be talking about stimulant use. And again, this is a top level review. We did a review of reviews. So what I'm talking about today is very broad brushstroke. I'm not going into the minutiae of evidence. I'm just saying, if we look at this in a very broad way, what do we know, what don't we know? And hopefully, I mean, I'll come up with my own ideas at the end about what this tells us. And I'm hoping that there'll be an opportunity for discussion so you can say, well, what you think it tells us. So there'll be 5 parts to the talk. I'm going to bore you a little bit with a brief overview of the global stimulant situation. And then I'm going to review the major harms quickly, because they're quite different than what we see for other drug types. And I think that's important for how we provide treatment. Then I'll talk about treatment and what the evidence says in terms of treating use. Then I'm going to go into what we know about treating harms associated with this drug. And then briefly move on to the future challenges and considerations, where I hope after that we'll be able to have a bit of a discussion. So firstly, the global stimulant situation. I'm going to be talking only about cocaine and amphetamine and methamphetamine. Amphetamine and methamphetamine put together. And that's because they're the stimulants where we see most of the significant harms associated with stimulant use, acknowledging that there are various other types of stimulants that are out there, and not to say they don't cause harm, but I just want to focus on the most prevalent ones. So firstly, amphetamine and methamphetamine. You can see a global map here. It's a heat map where more red is higher prevalence. Now, overall, the prevalence of methamphetamine and amphetamine use in the general population tends to be quite low. These data are from the United Nations Office on Drugs and Crime. They're quite patchy. You can see a lot of white where there's no data available. And often they're based on population surveys where people are underreporting. So they're probably an underestimate of what the true prevalence is. But the point is that on a population level, not many people will be using this drug. However, we also know that of those people who use, we estimate around 11% will become dependent on the drug. And in total, that comes to approximately 7.4 million people worldwide. And the point here is that even though the overall prevalence might be low, when we're looking at this as a drug problem, it is a significant drug problem that affects a significant number of people. In fact, it's been recognised as being a significant contributor to the global burden of disease. The recent costing estimate that came out of Australia put it around $5 billion per annum. So I think gone are the days where we can cast stimulant use aside as something recreational that we don't need to really worry too much about. It is having a significant impact on us as a society, and we do need to look at good treatment options for it. In terms of recent trends, and you'll see here, Australia has a fairly high level of amphetamine use, and New Zealand. In fact, up with the US, we're world leaders. We've also got a high prevalence in our region in Southeast Asia, although the data here is quite patchy in terms of prevalence. But we know historically it's been traditionally one of the leading drugs of concern in that region. In terms of recent trends, we've seen some really interesting things. With methamphetamine particularly, both amphetamine and methamphetamine can be quite easily manufactured, synthetic drugs, as I'm sure you know. And that means that supply can often follow some unusual paths because there's nothing to restrict it. You just need the chemicals and a safe place to do it where there's not too much regulation of those chemicals and not too much police activity. And what we've seen is trends toward it popping up, spreading, I guess you could say, popping up in unusual places. So we've seen a big increase in Cape Town in South Africa, for example, where it sprung up in the Cape Flats there. We've seen a lot of increase in Iran, and there it's become a production country as well as a country with methamphetamine use problems, whereas historically that was very much an opioid problem. We've seen increases in Mexico with the drug cartels there. And we've also seen increases in Northern Europe, where I think historically in Scandinavia there's been a lot of amphetamine use, but now there's been a trend toward methamphetamine use. So what we're starting to see is a spreading of this problem. In fact, in this paper reports on data from 2016 when there were 247 tons of methamphetamine or amphetamine seized globally, and that was the highest ever. It was 20% increase on the previous year, where I think it was 205 tons seized. So we're seeing a lot of production of this drug, and it's spreading to new areas. The situation we see with cocaine is a little different, and I'm sure again you're all aware that cocaine is really a drug that has dominated the Americas, and that's because it's produced in the Americas, particularly in South America, from the coca plant in Bolivia and Peru and countries in the Andes region. And so it's really dominated the USA and Canada much more than amphetamine, even though the USA is affected by both methamphetamine and amphetamine, and that's true of Canada as well. We haven't really historically seen a lot of cocaine use in Australia. But you'll notice here that we're red, and that's because recently there's been an increase in the prevalence of cocaine use in Australia, and it's now comparatively high up there with methamphetamine. Now, we haven't seen a lot of problems with that, but it's something to watch out for because it is a new trend, and while we're not seeing problems now, it might be something that we have to watch out for in the future. Now, stimulant drugs are always touted to affect specific population groups, and that's because of the effects that they have. Being stimulants, they enhance libido, so in the context of chemsex and things like that, they tend to be popular, but also very much occupational drugs because they increase vigilance and reduce fatigue. So people who are doing quite boring jobs like driving trucks, manual labor, it tends to be very appealing for those population groups. Now, having said that, for me, when I've worked a lot with people who use this drug, and I find it very hard to come up with a stereotype because this is a drug that's used by a wide variety of people for a wide variety of reasons, and the use patterns can vary from recreational through to very dependent daily use. So, I mean, yes, it does disproportionately affect these populations, and that's something to keep in mind, but don't go away thinking that these are the only populations affected. And naturally, polydrug use, as we all know, is a prominent feature with stimulant use as with any other type of drug use. Particularly in Australia, you see a lot of cannabis use. Alcohol use, even though it's fair and it's comparatively high for Australian standards, is not higher than the general population, really. We also have a lot of overlap with the opioid using population amongst people who use drugs, inject drugs particularly. So people who are injecting drugs will inject heroin, and then if they can't get heroin, they inject methamphetamine. But there's been an interesting international trend that I wanted to draw your attention to in the US and Canada, but particularly in the US, where they're starting to see an increase in methamphetamine treatment admissions and methamphetamine use amongst people who are using heroin. And that includes the co-use, co-injection of methamphetamine and heroin. Now, this phenomenon has been around for a long time. You can read about it way back in the early 1900s. But I guess it's come back into fashion. And one of the risks attached to this is elevated risk of overdose. And you can see here a picture of someone overdosing from opioid use. But what they've found over there is that the people who report this practice of what they call goofballing, of injecting methamphetamine and heroin together, were 3 times more likely to have an overdose in the past year than those who didn't. It's obviously non-fatal overdose. So what the concern is here is that the practice of injecting methamphetamine amongst people who are injecting opioids could increase mortality significantly. So in terms of reviewing major harms, I thought this was important, like I said, because methamphetamine, amphetamine are associated, and cocaine are associated with slightly different harms than what we see with opioid use. And a lot of our responses to dealing with drug use are geared, or have been historically geared, toward opioid use. Like we have methadone, we have naltrexone, we have needle and syringe programs for people who inject drugs. Whereas I think we really need to think seriously and hard about what are the major harms associated with stimulant use when we're tackling this problem. And firstly, fatal harms. You don't often think about stimulants as being associated with fatal harms. But my colleagues did an estimate of the mortality rates among people who use amphetamines and cocaine. And they looked at all the different causes of death, but the all-cause mortality was 6 times higher. So the standardized mortality rate, so these people dying 6 times more often than their peers because they're using stimulants, but basically this is the outcome. Their death rate is 6 times higher than their peers, regardless of the cause. And when we look at what was driving that, I mean, drug poisoning was the major thing, so overdosing, as you'd expect. So you can overdose on stimulants and die. But I think what's really interesting here is that stimulants, it's not like heroin where most of your deaths are just directly from the drug. But with stimulants, it's contributing to the risk of death from other causes. So, for example, increasing the risk of suicide. It also increases the risk of being involved with a homicide. It increases the risk of injury, car accidents and so forth. Also increases the risk of cardiovascular disease, sudden cardiac death and stroke in particular. And this can increase someone's risk of death. So a lot of these things go under the radar because they're not obvious that they're due or related to methamphetamine use, but indirectly, these the stimulant drugs are contributing to these other causes of death. Sadly, the highest fraction of death associated with the use of amphetamine dependence is reported in our region. You can see here on this graph. We are experiencing more fatalities related to this drug than all of the other countries in the world. Conversely, when you look at this for cocaine, it's disproportionately affecting North America, so it's basically the USA and Canada. There are also a range of non-fatal harms, as I'm sure you're aware, and I'll just run through them quickly. Dependence, I want to put up here in a highlighted form because often we forget that the dependence on any drug is one of the major harms associated and contributing to morbidity, premature life expectancy and so forth. poor quality of life, essentially. We looked at the evidence for a range of different mental health problems to see whether they're associated with stimulant use, and what we found was that it was associated with depression. There's quite good evidence for that for cocaine. It's actually reasonably good evidence for it being associated with amphetamine use as well, but not quite so strong. There's not so much research. Same with psychosis. The evidence for violence there's definitely an association there, but it's a little bit more tenuous what's going on. And we didn't find evidence for an association with anxiety. There wasn't much evidence at all available for understanding its relationship with amphetamine or methamphetamine use. So overall, we have significant mental health concerns associated with the use of this drug. So what we do see is elevated levels of depression and psychosis in particular, possibly also violence associated with the use of these drugs. We have probably under-recognised physical health morbidities, particularly stroke and myocardial infarction, so heart attacks. People who use stimulants are at a particular risk of what's called sudden cardiac death. But the risk of stroke is particularly important because I think what is happening here is you've got a comparatively young group of people who wouldn't normally experience stroke. And if you have a stroke early in your life, it can be associated with very significant morbidity, and that will carry through for the rest of your life. So this is something that we should actually be very aware of in this population. It's not just from the stimulant use, but these people carry a range of other risk factors from smoking, tobacco, and so forth that could be mitigated if we made an effort. As with other injecting drug use, we have a risk of blood-borne viruses and hepatitis C. And I think in addition, and what's particularly interesting with stimulant use is it's not all injecting drug use. And we also have sexually transmitted infections. The evidence that it's elevated for amphetamine use is a little unclear, but is definitely elevated for cocaine use. The process through which that occurs is debated, but definitely we see elevated levels of sexually transmitted infections in these populations. And I think that's important because not only in and of itself is it important, but it also increases the secondary risk of HIV. So BBV and STI risk is something we really need to consider as well. A couple of other things that are a bit different from opioid use and other drug use is non-fatal injury, car accidents, work-related injuries. I've just finished a clinical trial where we monitor adverse events throughout the trial. A number of people who've fallen off their motorbikes, cut their toes off or whatever is kind of surprising. And who knows what is driving this, but what we do see is an increase in these injuries, and there's quite good evidence of that. There's also evidence of decreased birth weight amongst people who are using stimulants and giving birth. And there's less known about the impact on Parkinson's disease, but there's concern about that, that it might increase the risk of Parkinson's disease. So the two other harms we need to consider here really are injuries and the impact on newborns. So moving on to treatment options for stimulant use, which is the primary point of the talk. We've reviewed the evidence for different pharmacotherapy options, and this won't take long to go through because there's not much evidence. In fact, there's quite a lot of evidence for cocaine use and less for amphetamine use, and all of what I'm presenting here is pretty much based on the evidence for cocaine use. And like I said, this is very broad brushstroke, so it's broken down into different drug classes. Most of what has been done in the literature is testing different psychostimulant drugs like agonist therapies or replacement substitute drugs like methylphenidate or dexamphetamine or similar stimulant-acting drugs to see whether you can give this to people who are using methamphetamine as a replacement and whether they'll stop use. Now, you'll probably be excited that there's a green here for go and there's a decrease in stimulant use. But before you get too excited, they describe the quality of the evidence for this as being very low. And it's a pretty modest effect. So it's almost like, yes, there's some indication there, but it's not a very strong indication. It's also based on data for cocaine, and the evidence, the reviews of the evidence around psychostimulant drugs for methamphetamine is not at all encouraging and really don't show any effect. So for us in Australia, where methamphetamine is more of an issue in terms of treatment provision than cocaine, it's not very encouraging at all. The other different types of drugs, it's not to say they don't work, but in terms of their effect on use per se, methamphetamine or cocaine use, they don't have any impact. So this is a little bit discouraging. There are other things that are in the wings that are being trialled, so we haven't given up. I mean, there's also 3 trials of naltrexone, as good as anything, but they've still got mixed outcomes. We still don't know where to go with this. There's been 2 trials now that have shown good effects with methamphetamine, so that's very promising. So we'll see where that goes in the future. I've just finished a trial of N-acetylcysteine, so we'll wait and see how that goes. Ibudilast, unfortunately, the results came out for that and it was negative, so that didn't work. Lisdexamfetamine is a long-acting amphetamine substitute, the kind of thing you think should work if you can get people to take it, but they've had a lot of trouble getting people into treatment for that because it's quite intensive, a lot of physical contact with the clinic. So, and I think that points to some of the problems we're having in trialing new psychostimulant drugs. It's very hard to get people into the trials and it's very hard to get people to take the medications regularly. A lot of the trials are quite small scale and really high dropout rates. And this has been a bugbear of the literature and it comes up again and again. We really don't have good quality evidence. So all we say things don't work, often they don't work because people in the trial haven't taken them consistently or people couldn't be followed up to get the results. So it's a real challenge for us as researchers to work out how to do these trials better so we can get good evidence. The bottom line though is that at the moment, no matter what people tell you, we do not have an approved psychostimulant drug. We do not know whether the drugs that are available are safe or effective. We know that they, for the most part, we have no evidence that they are effective. So we need to use extreme caution if people are prescribing these drugs off label and recognizing that we can't say with any certainty that they're effective. So that puts a lot of pressure on psychosocial treatment options. And hold your breath for this one because I'm afraid the results are not at all encouraging. And I'll explain a little bit more on the next slide about why that might be before you get too upset about it. So here's a list of psychosocial interventions. We have contingency management. And it's green for go, and you can see there that it's actually quite a solid effect in terms of increasing abstinence. Usually it doubles the odds of abstinence. This is actually really good evidence for that based on a number of trials. So we like contingency management, but that's an approach that isn't used much here in Australia, if at all. And then we have a few different interventions where we really don't know what's going on. And then we have all of the things that are usually done in practice. So screening and brief intervention, motivational interviewing, self-help, CBT, acceptance and commitment therapy. And you'll notice here, there's big crosses everywhere. So the meta-analyses that have been done today have not shown any benefit of these things over treatment as usual in terms of improving outcomes for psychostimulant use. So this puts us in an awkward position, but I just want to say, you know, while you're sitting there thinking, what do you mean it doesn't work? We treat people when they come out, they're using less methamphetamine or amphetamine than what they were using before they went into treatment. So how can you say it doesn't work? I think the important thing to keep in mind here is that these data are based on clinical trials. And this is important because we need clinical trials because they have an arm of people who are getting treatment as usual or getting no treatment. And what happens in these clinical trials is everyone improves. So it's very hard to get better than your treatment as usual group because usually when people go to treatment, they want to change. They're at a point in their trajectory of use where they're at a crisis. Naturally, their use will go down over time because they're coming out of that crisis. And they're also quite motivated. So when we trial all of these things against treatment as usual, it's very hard to get anything better as an outcome. So it's not to say that people don't get better after treatment. I think how you could interpret these data is there isn't one particular approach that works fantastically better than anything else. The only exception to that is contingency management. And now you probably already know this, so I'm sorry if I'm telling you to suck eggs, but I figure I should go through it for those who are not familiar with it. So contingency management is not an approach used here much, but it is used in the USA a lot in terms of at least treatment trials and trying to get it into practice. Where when people come in, if they can provide a drug-free urine, they get some kind of reward, usually a food voucher. So it's an incentivized abstinence approach. Now, importantly, a lot of people think contingency management is you just pay people for clean urines, and that's all there is to it. And I'm not saying that wouldn't work, but contingency management is a bit more sophisticated than that. And it's a schedule of reward where people are being disproportionately incentivized for having consecutive days of abstinence. So you can see here, if Johnny comes in and he gives a clean urine on day one, he gets a $3 reward. That's a very tokenistic amount. It's not going to do much. On day two, he gets a bit more, so say $5. And so that means his savings are $8 and then $2 more on the next day. And then if he's had 3 days of continuous abstinence, he'll get $25 because he gets a $10 bonus. And this is where it gets interesting. If he keeps going along those lines, he'll get, it'll keep going up. And so each day he's getting a little bit more than the previous day. And it starts to get to quite a significant amount of money. However, if he comes in and he gives urine which has methamphetamine in it, then it goes back to zero and has to start over again. So the motivation to keep up the clean urines increases because the reward increases. And from a psychological perspective, this is quite interesting because you can imagine that you're not just saying, well, if you take a day off your drug use, you'll get some money. It's more about changing someone's lifestyle. And if you can get them to have a number of consecutive days off, you're forcing a change in their habits, changing their lifestyle, and you're starting to instigate change. So just going back to this has been shown to be quite effective for stimulant use and other substance use in the USA, but we haven't done it here in Australia. So that's really all we've got in terms of treatment options for use. But we also have a lot of harms associated with this drug, which I went through before. So I want to briefly consider how we might approach treating some of these harms. So we do actually have evidence-based treatments for some of these harms. Psychotic symptoms. Now, this is interesting. We have antipsychotics to treat psychosis. They're not necessary. We don't know whether they're appropriate to be using people who are using methamphetamine and have drug-induced psychosis. However, we do know that there's quite a proportion of people, a minority, but maybe 10 to 20% of people who use methamphetamine will have a psychotic disorder. Often it's not treated because it's being dismissed as being drug related. I mean, I've tried to refer people into services for a methamphetamine psychosis when my team believe that they have a psychotic disorder. And the system is set up as such that they automatically go through to drug and alcohol services. They won't make it into the mental health system. So often these people are not getting the treatment they need. But we do have treatments for people with psychosis and we can use them. We just need to make sure they're applied. Depression, and this is really good because we know that antidepressants are effective in reducing depression. We also know that cognitive behavioural therapy is, and there are various other psychosocial treatments that also can work, including contingency management. So these are things that we might ordinarily use to manage methamphetamine dependence, and even though they might not be having a profound effect on methamphetamine dependence above and beyond treatment as usual, they can be used to treat depression in this context. The antidepressants, there's a bit of a warning there. Some of them are contraindicated for methamphetamine use, but not all of them are. So mirtazapine has been found to be effective in a recent trial and quite safe. Also suicide, it's one of the significant harms, and there are various different strategies that you can put in place to reduce suicide risk. So we need to apply these interventions to people who use stimulants. Also, significant HIV risk. I mean, I won't go through all of this table, but the point is we know how to reduce the risk of sharing used needles to reduce the risk of HIV and Hep C by providing sterile injecting equipment. We know that providing PrEP for people who are at high risk of contracting HIV, so men who have sex with men and people who inject drugs, it can reduce the HIV incidence. And doing that will reduce the risk that methamphetamine imposes on HIV. And we have treatment for Hep C. We just need to apply that to people who use stimulants. There's a lot we can do. Conversely, there are some things we really shouldn't do because they increase the risk of injecting behaviour, and that includes compulsory detention centres and arresting people and putting them in prison. So to close up, I've gone through a lot of bad things, like things where we don't know what to do for treatment and things don't seem to work as well as we would like. But I guess I wanted to end on an optimistic note instead of that. So it's like, rather than say, well, we don't know what to do, we can't do anything, what can we do? And this is my viewpoint, and I'm looking forward to hearing what yours is. But we know that with psychosocial interventions, we can optimize the outcomes, even if we don't have a magic cure. We can still improve outcomes by having good rapport with our clients, by improving retention, because if we have a good rapport, people tend to stay in treatment longer, and we know that longer stays in treatment are associated with better outcomes. Also, when we look in the community at people who are dependent on the drug, the majority of them haven't been to treatment for methamphetamine dependence, sadly. And I think we could do a lot of work just to improve treatment coverage access amongst people who use stimulants in Australia. We can also treat the mental health harms. We have evidence-based treatments for this. And often, because our systems for mental health and drug and alcohol are quite segregated, we don't do this terribly well. But we can do this, and we should do this, and this would alleviate a lot of the harms associated with stimulant use. And we also need to make sure our harm reduction strategies, which have been set up in most cases to deal with heroin injection, also reach people who are using stimulants. We need to make sure they get access to condoms because a lot of these people are sexually active, whether that's related to the drug effects or not. They're often a younger population who are partying hard and they're at risk for getting STIs and HIV. We need to make sure they can get sterile injecting equipment and treat other STIs and Hep C. What we shouldn't do, and it seems to be the thing that most often comes up in the media, politicians saying we need to provide mandatory detention for these people and arrest more of them, put them in prison. We know that that doesn't work, it increases harm, so we just need to keep pushing that angle that these are things we shouldn't do. But I think to do this, we need to put forward the things that we can do, and as I've just done. Some of the challenges that we will face into the future, I think we should be looking at more detail, a contingency management. Whenever I mention this to people in Australia, they poo-poo the idea. There's always reasons why we can't do it. People think that there are barriers to implementation, and they probably are, but I think that might be something we really need to think harder about because it is our only really strong evidence-based treatment option at the moment. We need to find a pharmacotherapy that works. That would be lovely. In order to do this, we need to change the way that we are doing the pharmacotherapy. We've tried again and again and again to give people psychostimulant replacement therapies. And what happens is they need to come to the clinic every single day. And for some people, that means driving from Penrith to St Vincent's Hospital while they're high on stimulants. That takes 3 hours to get their daily dose, and then they go home again and there's no time left in the day. So I think having medications that allow people to get on with their life, so we're trying take-home medications, but also taking a leaf out of the opioid substitution therapy book about depot medications, where it's more convenient for people. You can just give them a single dose. So we really need to look at that type of approach. We need to do a little bit more work on the treatment of the mental health. Yes, we can do that, but there's still some work we need to do to be able to provide guidelines on what is appropriate prescribing for antipsychotics and antidepressants, and linking services so that people can get good care for their mental health. And finally, this is a bit of a barrier that I like to push. When we're thinking about stimulant use, we're not only thinking about people who inject drugs. That is a large part of the problematic end of the population in terms of harms. However, when we're looking at treatment at the moment, we're looking at just over half of people going into treatment being people who smoke crystal meth, and they still experience harms, but they're not going to needle and syringe programs to get their clean needles. If they make it into treatment, they're getting exposure to people who can give them information on harms. But for a lot of these people, they just don't have any engagement with services. We need to really look at how to get information out to those people. And finally, at the moment, no one's really considered how to mitigate cardiovascular risk like stroke, or at least even address that, tell GPs to assess the risk of that. We haven't got anything in place to reduce the risk of injury. And at the moment, pregnant mothers, well, there's mandatory reporting and they might lose their children and they're less likely to go to treatment for that in some cases. So there are some serious issues there that need to be considered to reduce harm. So, in conclusion, stimulant use is a growing problem. It does present a challenge to health and justice services worldwide, and we need to make an investment in this area because at the moment we have limited effective treatments. Thank you.
Thank you very much, Rebecca McKetin. I'm sure everyone will have found that very informative. It was exactly as you said, it was a provision of what the research is currently saying around that, and we're most grateful because it's that actually instills what we do as clinicians in our practice. So much appreciated. I know it'll be useful. We've actually got loads of questions,
okay.
so please bear with me, and if you do need to rush off or do anything, just let us know and we can always go back to them later via email. I'll start off with, are you aware of whether there's an increase in methamphetamine use within prison corrections units and also within the Indigenous communities as well?
Okay, so firstly in prisons, I'm not aware of any data. I don't know whether it's increasing in prisons, but I do know that there is a large number of people who go to prison because of methamphetamine use. It seems to be overrepresented in that situation. I'm sorry, I can't answer whether or not it's increasing or not. Insofar as it's increased in the general community, I would imagine it's increased there as well. But then there's debate about that. We've certainly had increases in problematic use, and you'd expect those to be turning up in the criminal justice system. So I suspect it may have, but I can't confirm that. The second question about the Indigenous community, a lot of the Indigenous communities put up their hand when we had the nationalised task force, and were very concerned about the use of ice in their communities. That did seem to be more affecting some communities than others. And it's hard to get a handle on that because our National Survey of Drug Use does not oversample Indigenous people, which means that the numbers in that survey are so low that you can't really make anything of them. One of my colleagues, James Ward, has been doing research into this. He's, well, together we have, well, there's a large group of us actually who got an NH and MRC grant to do this. We've just done a survey of 700, just over 700 people, half of whom are Indigenous. So it's the largest ever survey of methamphetamine use in an Indigenous community in Australia. And that's just come out in Drug and Alcohol Review. If you're interested in looking at it, you can send it on. But that definitely suggests that there's use going on in those communities.
Definitely. Thank you for that. And I think, yeah, you mentioned the National Drug Strategy Household Survey. I think it's worth saying for those that aren't familiar, that they take place every 3 years, and we're also currently waiting for the latest results to come out, hopefully later this year, which is obviously, although it's only a small sample, as you said, it will give us another idea as to whether that figure's going up or down representatively. So it'll be interesting. Thank you. I guess we've got a couple of questions which are quite common, I think you'll be used to. There's research, you mentioned there's lots of research showing the co-occurring of conditions, mental health and substance use. Is there any evidence in terms of which one came first? And I know as an ex-dual diagnosis coordinator, I would get asked that regularly. So I will ask you to respond first.
Yeah, it's a bidirectional relationship in most cases. So for example, the depression is a really obvious one. People who experience depression are elevated risk of developing substance use disorders. Pardon me. But then if you look closely at patterns of methamphetamine use, when people go through the withdrawal, they experience quite profound depression regardless. And if someone's already got a depressive disorder, this can really exacerbate it. And we did one study where we looked at people coming into treatment, and over 80% of them had clinically significant symptoms of major depression. So they basically would have met criteria for major depression. About half of them said it was due to their drug use and it wasn't pre-morbid, and the other half said, yeah, I've always had this. And then when you look at them 3 months later when they've stopped using, it kind of flips over. So it wasn't really, I don't think that the people could judge whether or not it was the drug driving the methamphetamine, the depression, or vice versa. But I think what I did notice is that still quite a lot of them had major depression after they stopped using, which suggests that for those people, we still need to provide something additional.
Sure. And my experience as a clinician is often the substance use and mental health kind of kick in at around a similar age in a person.
Absolutely.
Which makes it very difficult to work out which one was the one that triggered the other, as it were. But thank you. Yeah. A number of people who use methamphetamine report that they're self-medicating for ADHD. Yeah. Is there any evidence, any research out there to show that ADHD is higher represented in that group?
I suspect it is, but it is across all substance use disorders, not specifically amongst people who use stimulants. We ask people whether they've been diagnosed with ADHD. It's self-report, but it's usually around about 20%, 10 to 20% would say yes. So I guess there are a couple of points there. Yes, it's true that it's probably overrepresented, but the majority of people who are using the drug don't have a history of it. For those who do have a history, dexamphetamine can be more effective. So there's some evidence that treating people with ADHD who use stimulants with dexamphetamine or methylphenidate can be effective, whereas that isn't the case if they don't have a history of ADHD.
Sure. Another question regarding mental health is a lot of people that use methamphetamine will get a diagnosis on that presentation of drug-induced psychosis. Yeah. Is there any research as to how many of those go on to develop a full-blown mental health diagnosis?
Yeah, so there's a few bits of research and they come up with different estimates, 20%, 40% in that vicinity. And it depends what you count as what time frame you use and what you count as a person coming into treatment. I think that's definitely the case if someone is severe enough to present to an emergency department with a drug-induced psychosis. We see a lot of drug-related symptoms of psychosis out in the community where people get paranoid and sit in their home and be frightened for a while, and then they go back to normal and they know it's related to the drug use and they just get on with life. But the ones who are severe enough to end up in the emergency department or the psychiatric hospital have a high risk of going on to being diagnosed with schizophrenia.
And we know ourselves as a mental health clinician that, you know, when you have a relapse in a mental health condition, then the prognosis of you having future relapses increased exponentially. And so that would make sense that would happen with substance use as well. The more mental health presentations you have, the more likely you are to go on and develop something in the future.
Yeah, and there's a real grey area. I mean, we have to admit, I am very fond of having a diagnosis of drug-induced psychosis because I see that a lot. But there's a real grey area where people really, they really do have something that's neither drug-induced nor doesn't meet the full criteria for schizophrenia, and that's a very difficult area to manage.
A comment from a Canadian attendee. I have no idea if they were in Canada listening in, but I shall let you know what they said. That you mentioned about the polysubstance use and mixing the heroin with methamphetamine, and the comment that the Canadian person said was that actually in Canada now, as you'll be aware, they don't actually see much heroin, they see lots more fentanyl. And obviously fentanyl being a much stronger opioid is going to massively increase that risk of overdose that you were talking about before. We don't seem to have the same issue at the moment in Australia, but I think it's certainly something we need to be aware of that does happen.
Absolutely.
You mentioned in one of your slides treatment as usual, and somebody's just asked, what do you mean by treatment as usual when you're comparing?
That's a really good question. One of the reviews that we cited there, one of the main reviews that we cited, they talk about it, they define it as usually group counselling. So quite a generic intervention.
The more psychosocial side of things, I'm guessing.
Yeah, it is. It's, I think, one of the bugbears in this area, trying to research it, is how you actually define what treatment is. And it could be so many different things. And sometimes when you average across that, well, who knows what you're getting.
Sure. Now, we've looked at treatment for stimulant use. Somebody has actually asked, and I know this used to happen many years ago, is there any evidence in stimulant use for the treatment of treatment-resistant depression?
I'm just getting my head around that question. Double barrel, triple barrel.
Is there any evidence for using stimulants in people who are resistant to other forms of treatment?
Yeah, well, it used to be, amphetamine used to be used as a treatment for depression, as I'm sure you know. And I don't think it is anymore because of the risks, and I wouldn't advocate for that. I mean, of course, I think the issue is short term. Yeah, it works brilliantly, but with any heavy exposure to a stimulant drug like methamphetamine, you get a rebound in monoamine function. It's quite profound, and that induces depression. Not to mention the risk of paranoia and the dependence liability. So I would caution against that, given the history of treating treating depression with stimulant drugs.
Yeah. A couple of questions on contingency management, which is what I expected. When that came up, it tends to generate interest.
Yeah.
So is contingency management more effective when combined with the more traditional methods of treatment, as we were talking about earlier, the psychosocial approaches?
Yeah, that's interesting. I didn't see any evidence of that. I mean, it might be. There's some evidence that when you add it together with CBT, you get better treatment outcomes. But I think it's really the contingency management that's driving the impact, it seems.
Yeah. And in relation to that, is if somebody was using contingency management, is it tapered off or stopped at the end of that treatment program? And also, how long do you think you would need to do contingency management for to have a good outcome of sustained abstinence at the end?
This is exactly the $1 million question, and it's the question that I ask and I want to ask my colleagues. And one of the criticisms is that people say, well, contingency management works while you're doing it. And then other people will say, well, that's true for all treatments in a way. Like, we don't have any treatments that you can give for a week and then walk away and the person's better forever. That would be great if we did. But then when you're increasing the rewards over a long period of time, how long can you go on for? Yeah. And it is the question, like, how long do you have to do this before you establish a new habit in that person's lifestyle that they can sustain? And when you do taper it off, like whether that be after 3 months, 6 months or 12 months, do you have to put in place other supports? How do we implement this on an ongoing basis? So it's a great question.
Yeah, not one we can necessarily fully answer yet. A couple of more questions, if you're still good for time. Is there any evidence for naltrexone implants as a pharmacological approach for management of this?
So there were 3 studies that we looked at that looked at naltrexone, and they didn't have consistent findings. Just really frustrating. So you get one positive result and you go, well, yes, this works. You get another negative result. So you go, well, it can't be replicated. And I think if you could get a good result with the the short-acting version of naltrexone, that would pave the way for trialling an implant. But the problem is, I don't think you would get approval to trial an implant if you didn't have really clear evidence of effectiveness of the short-acting dose. And at the moment, we don't have clear evidence that naltrexone works.
No.
We have very ambiguous evidence. And maybe in the future, if they can do enough trials that overall show a positive effect, then yes, implants would be the way to go. But at the moment, we don't have that.
And somebody's asked about, you know, the Suboxone for opioids. We don't have anything that's shown anywhere near that sort of efficacy for people who use methamphetamine at the moment.
They've still got a lot of work to do on the pharmacotherapy side.
I know this isn't necessarily about treatment approaches, but are there any safety issues or concerns around the use of antipsychotics when used with someone that's experiencing methamphetamine psychosis?
Yes, and this is why I think we need a bit more research. I mean, clearly they're effective for people who have a psychotic disorder, so schizophrenia is where they're usually indicated. But in that context, some of the antipsychotics have quite a strong adverse reaction profile and really quite serious side effects. Yeah. And so this is a real concern. Like, you don't want to be putting people on very strong medication that can be harmful, and particularly if it's not doing them any good. And we know that with people who have psychosis, if they're on antipsychotics and then they use methamphetamine, the symptoms of psychosis come through still. So it can undermine the efficacy of the medication. So we're hoping that we'll be able to sometime in the near future trial antipsychotics for people who have people who use methamphetamine also have psychosis, that kind of borderline group who not clearly drug-related psychosis and not clearly schizophrenia, and see whether it can help them. But we'll be monitoring the side effects very carefully to make sure it is safe. Having said that, you know, the new generation antipsychotics are becoming quite popular amongst the people that I see who use methamphetamine. We're seeing quite high prevalence of antipsychotic use, and we don't know whether that's doctors just going, well, it'll reduce agitation, we'll give it a go, or whether they're getting it on the black market. But I think it's out there and it's being used, so we really need to look into the safety.
And I should say on that, we actually had a presentation, I think it was the week before last, on Psychol or quetiapine. Because of that reason, we knew that a lot of our guys, for example, that use methamphetamine were also using that as well. So thank you. I have loads more questions. I'm not going to get to all of them, so I apologise to those that have written them in. I'm going to ask one more, and then I'm going to hand over to a colleague of mine who stood next to me, because he's also itching to ask an expert some questions while we've got you available. So the last one from the panellists, and thank you people that are writing in, is there any evidence linking stimulant use and trauma?
Well, in the people who use stimulants and other drugs and have dependence on those drugs, a significant proportion of them have experienced trauma in their life, particularly like sexual abuse when they were young, violence and so forth. So yes, it obviously is a risk factor for the development of substance use problems.
Definitely. And I would say that even if it wasn't prior to using, quite often the use of substances and the world that can lead you into can then bring trauma in, even if it wasn't there before, which can exacerbate the problem. So thank you. I'm going to hand over to Dan, who's got a couple of questions for you, Rebecca. So please, Dan.
Yeah. Hi, Rebecca. My name is Dan Phillips. I'm another one of the educators here. Thanks for your presentation. It's interesting, the huge impact that methamphetamine has in Australia, and then we have this treatment contingency management with such good evidence, and you mentioned there are barriers. So I'm just sort of confused, you know, what are these barriers that prevent us using this effective treatment?
So when I've talked to some of my colleagues about, you know, why aren't we doing this, because I have that reaction, and they say, one of the first barriers that was put forward to me was that you're urine testing people, and that undermines the therapeutic rapport you have with someone, because it sounds like you don't trust them, rather than just letting them decide what they want to do about their substance use and set their own goals. It's a very top-down approach, I guess. And it was interesting because at the time that this was raised by one of my colleagues, there was a lady there who had previously been dependent on stimulants, and she'd gone through contingency management, and she was quite angry, and she goes, "That saved my life." You know, what do you mean?
Yeah.
So obviously there are different perspectives on that. The other argument that I've heard is that politicians will never support it because you're paying people who use drugs to stop using, and from a moralistic perspective, there's a sense that people will reject that, like the general public would reject that as being inappropriate. And then there hasn't been a lot of, well, there's some evidence of uptake in the US, but I think there are some questions, as one of the speakers raised earlier, about how you would actually go about implementing this in a practical situation, how long you would have to do it for, that type of thing. So I think there are political barriers to it. But I mean, my personal approach is, well, we should try it and see. Engage with people who have lived experience, see what they think of it, let them choose. And I mean, we've overcome barriers to other things, like when needle and syringe programs were first proposed, people were opposed to them. People are often still cynical about methadone, but we know that it's had a lot of benefits, public health benefits, help people reduce the risk of overdose and so forth. So I think it's something we really do need to explore a bit more.